Great. Now I'm excited to welcome and introduce our presenters for this afternoon, Maya Hartigan, founder and CEO of May, and Alicia Lalani, head of growth at May. May has been a longtime partner of MHPA, and we appreciate their continued engagement and support of MHPA and our member plans. Maya and Alicia will be presenting today's webinar titled A Digital and Community-Based Approach to Address Disparities for Black Expectant Mothers. With that, I will go ahead and turn things over to Maya.
All right, thank you so much, Eric, for having us. Alicia and I are really thrilled to have the opportunity today to share a little bit about our work at May, particularly on this first day of Black History Month. I think for those of you in the audience, right, none of us are strangers to the impetus around the US maternal health crisis or its impact on the health and livelihood on women and babies of color in particular. Today, I wanted to kick us off by sharing a little bit about our first May-supported birth. We'd engaged an expectant mom with weekly health tracking, with digital education and support, and we'd also connected her with a culturally aligned doula in her community who was able to be in the room to attend to her birth. This mama was pregnant with twins, and she was also covered under Medicaid insurance. And the outcome of this birth was 2 healthy babies, born vaginally, born without pain medication. I will say that this was this mother's preference. It was not my own when I was having my children. But it was a positive birth experience all around, with our mama feeling that her birth preferences had been acknowledged, respected, and nurtured on the day of. And while this should be the norm, not the exception, it is indeed the exception, particularly for women who look like me. And for our team, this was a really important early signal for us, right? A positive signal of what could happen if we really worked to create the right set of circumstances and to wrap our mothers with the specific support they needed to be both successful and respected in their desired experiences. And so our work at May from this point onwards is really about bringing that outcome to as many as possible and turning what should not be extraordinary, but is in this current moment, into the norm. So let's dive into why we're here. And as you all know, our healthcare system is deeply inequitable, and it is particularly failing Black mothers, right? Where we are more likely to have our babies prematurely, often with lifelong health consequences for our children. We're more likely to experience C-sections, whether or not there is medical necessity. We are 3 to 4 times more likely to die a pregnancy-related death, even when adjusting for income and education. And what we know is that many of these poor outcomes are avoidable, right? And despite that, they're driving billions of dollars of spend into our national healthcare system each year, where we have, for example, an estimated $26 billion each year spent in the US on preterm births alone, right? Where low birth weight babies may cost you as health insurers about 10 times what you would otherwise spend on a baby of a healthy weight in that baby's first year of life. And we know that about 15% of Black births are preterm. We also know that about 36% of Black births are C-sections, and that's estimated to be about double the number deemed medically necessary, each at about a 50% higher cost to payers. When we talk about these cost impacts, it's important to point out that we're speaking to the current pregnancy, but we also know that these are issues that compound and create both unsafe and costly outcomes for subsequent pregnancies as well. And so there is really great incentive to invest in the prevention of these complications and to invest in the avoidance of these massive costs. And we're starting to see that across the board. We're seeing it in new federal legislation. We're seeing it in state level mandates. We're seeing many insurance companies and also health systems make meaningful investments in improving care and reducing costs, and doing so with a heightened focus on marginalized communities, which is long overdue. So what is behind these poor outcomes, right? What we know here is that it's incredibly multifaceted. First, we know that prenatal care engagement rates tend to be fairly low, with about 1/3 of Black women not receiving any prenatal care in the first trimester, where we know, right, that so much of that initial screening and those preventive measures really need to be put into place to change the trajectory of that pregnancy. We also know that much of this is driven by a clear lack of access to care, right? And that's both at the micro and the macro levels. And these barriers can range from an inability to get off work during the right hours to challenges with transportation, all the way down to geography, right? As we continue to see hospital consolidation and the emergence of maternal health care deserts, both in urban and rural areas. Thirdly, and I think it's very important to say that this is also driven by that generational lack of access to care, is that we are entering into pregnancy with higher rates of unmanaged chronic conditions, including things like diabetes and hypertension, which are also contributing to these preventable pregnancy complications. And the piece that really underpins and often exacerbates these problems is an insufficient cultural sensitivity in the care of Black women. That's bias, and it's sometimes explicit racism in care that has now been well established and is really leading to a lack of empowering care that leaves room for self-advocacy and also the building of trust between Black women and those providers serving us. And so at May, we are laser focused on redefining this standard of care for Black mothers and really focusing in on holistic support. And our first step is digital engagement that is continuous, right? And we're leveraging our digital platform as one of the first resources that's accessed by newly pregnant Black women. And we're using platform features, including a weekly check-in tool to really support that self-tracking of physical, emotional, and social structural, but with a very specific focus on monitoring those risks at a point where interventions are still actionable. And I know for so many of us who've had children, right, even during our own pregnancies, it's really hard to know how to check in on yourself or what questions to ask. And so this is largely about removing some of that uncertainty from our mother's hands and creating those ongoing and trusted touch points and a pathway for early risk ID that our payer partners are desperately seeking. We've built an issue escalation workflow around each of our tracking questions so that mothers can see real-time guidance on next steps in their care, as well as educational resources speaking to those risks, and also lifestyle and pregnancy management needs based on stage, but all built with cultural competency and cultural responsiveness in mind. And while this digital component of our offering is substantial and something that we really believe in as a team, there is also an acknowledgement that when we think of the complexity of root causes in this space, that the digital support in and of itself is likely not enough, right? And so there's a huge complexity there, right? That also just includes well-established bias in our care, right? And so the second core component of our offering that we're very focused on is local and culturally aligned support from community-based doulas, really folks who can serve as trusted advocates and partners in care to our mothers. And so everything that we're doing and learning on the digital side is feeding into a broader support model that leverages these local doula partners, right, as trusted partners to our mothers throughout their pregnancy, labor and delivery, and postpartum journey. And so ultimately, in addition to the digital platform encouraging literacy and ownership of one's own health and care, this wraparound support from our doula partners also is enabling that individualized and whole person focus that we so deeply believe in. And this is the component of our solution that we really believe has the potential to work towards improving those perinatal experiences and outcomes for the mothers we serve.
So as we think further about our solution, we've been very intentional in designing a product with the highest potential for clinical impact, from very early days of pregnancy all the way through the postpartum period. And we've really prioritized our product priorities on these evidence-based interventions that set the highest standard of care for perinatal care, but also those priorities that will offer that potential to deliver against the operational and financial priorities of our payer partners at every stage. And as an example here, it's well established that things like one-on-one intrapartum support from doulas, childbirth education, and birth planning can reduce those non-medically indicated C-sections and preterm births. And so these are interventions that we weaved into our platform, into our experience, and with our focus on a community-based network of maternal health experts. And these interventions are well established and are ingrained in many maternal health programs. But May's particular focus on the cultural resonance and the common lived experience across these interventions and across these stages of pregnancy and postpartum really creates that familiarity and that stickiness that reinforces the efficacy of these interventions. So at May, we take these culturally congruent interventions and create wraparound support for these birthing people across in-person and virtual and digital care models. And that variety in care models here is an actually important distinction and has been particularly important for the demographic we want to serve. May is digital first, as Maya mentioned, but not digital only. And our hybrid model of support, which is not limited to just virtual, but in person as well, really allows us to provide that full support and optimize that doula benefit, especially in reimbursement states and markets for our Medicaid plan members, for example. On the user side, while many of our users are technologically savvy, some occasionally do need that higher touch of support to engage around the risk tracking and the doula benefit and the like. And so this is an area where we lean on our May Care coordinators and our doula partners. Our social support layer really ensures that May users are completing those weekly check-ins and getting that guidance, that education, and those next steps required for any identified physical, behavioral, emotional, or social structural needs. And in instances where these needs require escalation, May has designed customized workflows with our plan partners and automated data passback around these care flags to ensure that clinical care managers and the May team have visibility around these individual members to work together and determine what the appropriate next step is in a collaborative way. We're really deeply integrated with our plan care management teams, and we have that focus on appropriate and timely medical care, but also optimizing the benefits use to ensure that right care at the right time at the right place for all of our users. So we'd really love to share at this stage how we're doing. When we were launching May just last year, we heard a lot of skepticism. We were often told that this population would be difficult to engage and wouldn't take action in their own care. And our experience has really challenged that narrative in a very positive way. So at a high level here, right, of the members that we have contact information for in our live plans, we've achieved a reach rate of about 70%. And that's where we were told we would be lucky to achieve about a 5% reach rate here. We've been able to achieve that 70%. Of those members reached, we've been able to convert 23% to May users. And of those users, 95% have engaged meaningfully with our solution, whether it's through our risk tracking tool, a doula visit, completing a birth plan, or a combination of those. What's even more compelling here, though, is that 61% of our users triggered a doula touch point within that first week of enrolling. And this is really meaningful for lots of reasons, but it's this relationship that's key to driving the outcomes that we're wanting to see. And I think the other big piece to share here is that of our users, 62% have indicated a care flag. So this can be a mild to potentially significant concern around those physical, behavioral, emotional, mental, and social structural concerns. And we've been able to pass these care flags back to our care management partners on the plan side. And these would have been unknown care gaps, or these would have been unknown risks to the plan otherwise. And so through this close collaboration, we've been able to close the loop on 100% of our social determinants related flags. And we've also been able to close some of those care gaps in partnership with our health plan partners. And so while it's still early days for May, we did want to share a bit on our early impact. We already shared that our reach rate has been much higher than expected, but beyond that, our early birth data is really promising here. So for the users we've supported through a combination of May services, the digital engagement, the doula support, or both, we've observed about a 53% reduction in C-section rates and a 44% reduction in preterm birth rates. Those are against the national statistics that Maya shared at the beginning. And we often know in Medicaid plans that baseline data is even more dire than those national statistics that we're using here for comparison and the baseline. So thus far, we're really pleased. And as we grow and continue to evolve May's offering, we hope to evaluate every single user experience and really drive into every point of data to ensure that we're getting stronger, our solution is getting stronger, our output's getting stronger, and we're continuing to move in the right direction here. I think beyond our quantitative impact data here, we're also just getting a lot of positive feedback from users, right? We're hearing that they appreciate having a solution that speaks to them as Black women, and that these are sort of the solutions that in the past and in their past pregnancies have felt out of reach to them. So we're so honored now to be part of the solution here. So just really grateful here.
All right. Thank you, Alicia. And I can see that we have had a couple of questions come in. Please keep them coming. We would love to use this opportunity to help all of you learn a little bit more about what we do. One question I'll respond to quickly: does May offer peer support virtually or in person? The answer is that we do both, right? So I think it's important to share that when we were in the earliest days of May, right, we did a very, very rigorous review to understand what are the established clinical interventions that have been shown to work, particularly for this demographic we're serving, right? And one of the critical components for us was that in-person intrapartum support from doulas, having doulas in the room during labor and delivery was a really critical factor, right? So as we're working with some of our early plan partners and in deployment planning with some of our next most immediate plan partners, we are prioritizing building these community-based feet on the ground proximate to the members we're serving, wherever that's possible and feasible, right? I also think that's very important because we know that where in certain states where the Medicaid regulations are falling around doula coverage, often there's some flexibility, right, in reimbursement for doulas remotely or in person for prenatal and postpartum support. For the labor and delivery event, we're generally seeing those regs only align to in-person support, right? So part of this for us is just making sure that we're driving trust, we're driving, an awareness of folks and continuity of that relationship, but we also want to make sure that we're working with plans in a way that they can fully optimize that doula benefit, right? So we are prioritizing in-person support where we can, and we're offering it virtually where we can't. All right. Another question here, do we have a national doula network available for in-person visits? The answer to that is no, not yet, right? So that is what we're building towards. When we think about the way that we're working with our current Medicaid plan partners, it really is an exercise of understanding what state we're going to and what region within that state we want to focus on, right? Based on what I was just saying, it is very important to us to build these partner networks proximate to the members, right? And so that is a resource intensive activity for us. We have a first 10 states or so, Alicia can correct me if I'm off on that, but an initial 10 states or so that we focused on building those relationships in. They are states that align to May's mission demographically. They are also states where we have some existing or near to hit plan partnerships, right? And so for us, because that is such a resource intensive activity of building those local doula networks, working with those doula partners to help them register with the state to become Medicaid providers and the like, we are really letting our contracts lead, but we do have a handful of strategic states where we've been doing that proactively even prior to having some of those contractual commitments. And so we're building in line with the demand and in line with our contracts, and we're scaling as fast as we can as a company, which is really exciting. Do we have lactation consultants? Yes. So many of our doula partners are also certified lactation consultants, not all of them, right? So if that is a priority of our plan partner, we are also looking to find and engage full spectrum doulas who may also be certified lactation consultants. Many of the doulas in our network are. So the clinical and physical support. Yeah, so sorry, I have a question here that says, can you say a little bit more about the clinical and physical support offered? And one thing that I will say about our model, what we're doing digitally on the platform, which we did describe a bit during the presentation, is that we're doing what we refer to as continuous risk ID, right? So we've worked very closely with our medical director, Dr. Michelle Owens, to evaluate what sorts of things, our users can self-identify and flag, and we're prompting them to monitor these sorts of things, share, right, how they're doing on our platform. We tie those to risk flags that we are then able to share with our care management partners at the plan through automated data passback. Urgent risk flags go back within 24 hours, non-urgent things that may be more oriented around benefits coordination and the like would go back against a less frequent cadence as code-defined between May and the plan. But those are very much focused on physical risk factors, emotional risk factors, social structural barriers to care. When we think about the doula component of our offering, that's a little bit different, right? In that doulas are not licensed medical professionals, right? They are peers and guides for emotional support, pregnancy education, and the like. And so in that sense, they are not medical experts, right? Although they do have a great degree of medical literacy and knowledge, right? And so we are not practitioners. We are not care providers. We are not providing diagnosis or anything like this, right? But we are serving more in a educational and support capacity for our users. The physical needs and risks that we're IDing and passing back to our care management plan partners are going back to them so that we can help to coordinate next steps, touch points with doctors, screenings, all of these sorts of things. And so we do play a role in the coordination and follow-up around those physical needs in pregnancy, but we are not administering physical care, if you will.
Thanks, Maya. I think we do have a question around if we can provide an example of the interaction and coordination with the payer's case management team. So I'll give a very definitive, finite answer here, for example. So in our, for example, week 16 weekly check-in, if we had a user or a birthing person come on and say that they're experiencing food shortage or some food insecurity or the like, or they're not able to get to nutritious food that they're worried about for themselves or their baby during their pregnancy, that's something that we take back. And so we have two big components of care flags. And so one is an urgent care flag. So if there's something of clinical concern that we think, hey, maybe there's something going on, we send that back within 24 hours to our care management partners on the payer side. The other is sort of a social determinants need or a non-urgent care flag that we pass back every 2 weeks. So in this instance, we pass back that flag to our care management teams, and we were able to collectively figure out that, hey, you know what, this plan actually has a nutrition pharmacy and a program that provides meals that are nutritious, and it's actually covered under the benefit. So we were able to, as we were discussing that particular case, realize that this is a benefit that the mom could use or the expectant mom could use. And so we were able to go back to her, help her get signed on to that program, make sure that she was getting what she needed. We had the correct address, so she was able to get those deliveries and the like on time. So that's an example, but I think that sort of ranges right from not just nutritional support, but transportation support. And if something were to come up around housing, clothing, things like that around the SDOH piece, I think that's something that we're seeing pretty often, and we're seeing those SDOH cases a number of times. We're also on our end keeping a pretty up-to-date benefits cut sheet of our plan partners. So we're able to, on our care coordinator side, say, hey, this is something that's that your plan already provides. So we don't necessarily need to take it back, but we can refer them back to that benefit quickly, just so they're aware, because we often know that there's a number of benefits that plans have that are not being utilized appropriately.
All right, I'll take a next question. Can you please I'll take a next question. Can you please explain the initial engagement? Is it digital or is it in person, leading to the use of the digital components? So we are a digital first services business, right? So our first touch point with users is typically actually a telephonic outreach from our care coordinator, right? We receive a roster from the plan. We do outreach to folks on that plan roster, typically via telephone, via text if permissible, and also via mail, right? Once a user onboards onto our platform, that first touch point and engagement is digital, right? So they'll come on, they'll tell us a little bit about their pregnancy and stage. They'll do that first weekly check-in. They will confirm their insurance so that we can map them to the appropriate iteration of our experience, right? For example, displaying the practitioners who are approved for participation and reimbursement for one of our specific Medicaid plans. And then we'll go from there, right? So we are digital first. Our digital platform is really our foundation for connection, for risk ID, for continuous engagement. But again, we're funneling much of what we learn from that digital engagement into the touch points that are more white glove that follow, right? Whether it be with those doula partners or with the care management entity of the plan. Okay. Another question here is, how are you supporting doulas? This is a really, really good question, right? I think we're at a point of we're at a little bit of an inflection point, right? Where I think doulas have been extraordinary resources in communities for generations, right? Certainly for decades. And we're at this inflection point now, I think, where there's a broad realization around the value they bring, right? Both in terms of pregnancy experience and satisfaction, but also with respect to clinical outcomes, right? So our role with our community doula partners is really multifaceted. We do work with individuals. I'll use the example of a reimbursed doula Medicaid market, right? So taking the example of certain states, Maryland, Michigan, soon to hit in Illinois, so on and so forth. When we're working in one of those states with doula partners, we work very closely with them to help them get an NPI, to register them with the state Medicaid agency so that they are eligible for reimbursement through Medicaid in the state. We then, once we're through that process, work with our plan partner to ensure that they are onboarded as a plan side provider and on the plan's roster. We support with documentation needs and the like to ensure that that happens seamlessly. From there, our objective in working with our community-based partners is really to let them focus on the parts of the work that they love, right? And so what we are doing is providing quite a bit of administrative support around scheduling, but also around managing claims and billing, right? Because I think one of the important points of feedback that we're hearing from a lot of community-based doulas is that they love the fact that doulas are becoming a Medicaid reimbursed benefit, but there's still a lot of red tape. There's a lot of bureaucracy. There are a lot of hurdles in terms of being able to participate, being able to get paid. It's a very difficult thing for them to do, right? And so part of our role in working with these partners is taking on some of those messier aspects of the work, right? So that we can, for example, manage all claims on their behalf and work with the plan to make sure that clean claims are submitted and can be paid in a timely manner. And the like. And then we're working with those doula partners as well around, capacity management and just ensuring that we can work together as a team to deliver on behalf of these moms. But again, with our taking on a lot of the messier administrative components so that they can really focus on the work they love. All right, Alicia, do you want to take the question on WIC?
Sure. So one of the questions is, do you have any partnerships with WIC? So we at this point don't have any direct relationships with WIC, but we are working again with our plan partners if they have relationships with WIC, if we have community-based support that has relationships with WIC, but at this point we don't have any direct relationships with WIC.
All right. Language interpretation services, we have one question which asks if we're currently supporting any language other than English. We are not as of this point. Or Alicia, I'm happy to take this one.
Yeah,
our digital platform currently is only in English. What I will say that we've been prioritizing doing as a team is working with certain plan partners just to understand the language requirements or needs in the communities we're serving, right? And to the best of our ability, we're trying to recruit that partner network of doulas to be in a position to work in the language that is needed in that community, right? And so if that's a Haitian Creole in Florida, or if that's Spanish-speaking folks in Texas, right? So we're leaning into that a bit. We haven't, as of this point, evolved our digital platform to support languages outside of English, but we will be prioritizing that as it's required by some of our early plan partners. We also have one question about our name, which is MAY an acronym for something? MAY is not an acronym, and this is actually a little bit of a funny story. When I was naming MAY at the point of founding, I wanted to name the company, in a way that was a nod of gratitude to a health equity champion. That nod of gratitude for me, the person I had in mind was Dr. May Edward Chin, who was the first Black woman to come out of Bellevue University Hospital Center, which is now NYU's medical school. I will acknowledge her name is M-A-Y, and I was insistent on naming this company after her. And in the end, I modified the spelling a little bit because the name felt a little bit close to mine and that didn't feel appropriate. But I would still say that, our company's name is a nod of gratitude to, Dr. Chin and other health equity champions like her. And I think, Eric, with that, I'm not seeing any other questions, so we would be happy to respond if there are more.
Yeah, absolutely. Thank you so much for your engagement, everybody. Love all the questions that came in. Obviously, if you do have any more questions for the May team, please feel free to reach out to them directly. As I mentioned earlier, they will be including the presentation slides in their follow-up messaging, and I'm sure they'll also include their contact information there too, so you can reach out directly. Thank you, Maya and Alicia, for that incredibly informative and insightful presentation. As I mentioned at the top, you will be able to find the recording of this presentation on MHPA's YouTube channel if you ever want to revisit it in the future. We really appreciate the entire May team sharing their expertise and leadership on this very important issue. And finally, thank you to everyone who joined us today. We hope that you found today's webinar to be valuable and you plan to join us again next week for next week's installment. With that, we'll go ahead and close. Thanks, everybody, and have a great afternoon.
Thank you. Take care.
Bye-bye.